This technique is done in a short sitting position to work on knee mobility, focusing on the joint between the tibia and the femur. So again, I'll show on the skeleton first, and then I'll show on the knee over here how this technique can be done. So what I'm going to do is apply a little bit of traction to the lower leg towards the floor, and then at the same time I'm going to apply a relative posterior glide to the tibia in a relatively flexed position. So again, be as close to the barrier as possible for flexion. If the barrier happens to be around 90, which is a common barrier for flexion, people kind of get stuck there for a while. I'll be at this 90 degree, go to the barrier, apply traction, and then I can give a posterior force of the tibia under the femur, and I can even emphasize a little bit more of that medial rotation if I want with that posterior glide, kind of the opposite of the screw home mechanism. Right, so what I like to do is apply traction with my lower legs, like so, and then I can just let my knees drop. I don't want to break the skeleton, but that would provide traction. Then I can come in with my hands here and give a little bit of a posterior glide at the same time. We'll show that on the knee here. So assuming the block in mobility is about 90 degrees, I can come like this, and hopefully with the soft part of my lower legs, just let my legs drop into some extension of my knees. That applies a little bit of traction to the joint between the tibia and femur, leaving two hands free then to come in on the front of the tibia and just give it a relative posterior glide. Again, I can emphasize just the medial part if I want, or I can emphasize both portions with that posterior glide to increase flexion from an arthrokinetic standpoint at the knee. It's a nice technique. It works really well for people who maybe can't get supine or don't tolerate that much mobility in supine. It's a pretty gentle technique. Could also come from the opposite direction, still provide traction, scoop behind and just give a little bit of an anterior glide. Obviously I'm not at the barrier of extension in this case, but for an anterior glide in flexion, lots of patients tolerate that pretty well. I can almost just kind of scoop it up and around like so.